and pacemaker therapy. We start with a question. An 80-year-old man complaining of episodes of dizziness. His physical examination and echocardiogram are all within normal limits. A looping event recorder was prescribed, and this strip was obtained during another episode at 3:40 a.m. while walking to the bathroom. Look at the, I will show you the strip in a better way. So look at the strip. And then the question is, what is the next most appropriate step in the management of these patients? Is it amiodarone 200 milligrams daily, catheter ablation for atrial fibrillation, VVIR pacemaker implantation, DDDR pacemaker implantation, or a bedside commode? Now, if you look at the electrocardiogram, the first two beats are actually atrial fibrillation. And then you get a pause, and then you get a sinus rhythm. I will try to move the pictures here to the right so we can see a sinus rhythm. So this is an important point. Patients with atrial fibrillation, they do not get episodes of dizziness or syncope because of the atrial fibrillation. This is very unlikely. It might, but very unlikely. But they get that because of a pause. And the pause is usually due to the acceleration of the ventricular rate during the atrial fibrillation, suppressing the sinus node. So if you find this picture, you think of tachybrady syndrome, or a thick sinus syndrome, or a sinus node dysfunction. And if you look to A and B choices, amiodarone and catheter ablation for atrial fibrillation, that's not a problem. The problem of the patient is the episodes of dizziness due to this long period of asystole. And therefore, a pacemaker implantation is indicated. And this is a paroxysmal atrial fibrillation. So this patient is not a candidate for VVIR, and I will detail on that in the subsequent discussion. But the correct answer is a DDDR pacemaker implantation. Obviously, a bedside commode is only indicated if the patient refuses treatment, which is very unlikely. Now, the truth of matter is that bradyarrhythmia come in two flavors. Either abnormality in the sinus node, in which the sinus node, because of abnormal in the IF current, cannot form electrical impulses, or it forms the electrical impulses very well, but it cannot make its way to the ventricles because of heart block. Either way, in the acute stage, you give atropine for a vagal component. You can implement the temporary pacing, or you can withdraw an offending agent, which is commonly a drug. But on the long run, all of these patients need permanent pacing. Now, we discuss shortly sinus node dysfunction. This refers to a variety of bradyarrhythmias. Inappropriate sinus bradycardia, which is a slow heart rate all the time. Sinoatrial exit block, which is can be first degree, second degree, or third degree, the same classification like AV nodal block. Although from the surface electrocardiogram, you cannot diagnose except the second degree SA block. You cannot diagnose first degree or third degree until you obtain an electrogram of the sinus node, which is not a common thing to be done nowadays. Or you can get a chronotropic incompetence. And actually, the literature is divided on the definition of chronotropic incompetence. Some experts define it inability to attain the patient 100 beats per minute. Others define it inability to attain 60% of the maximum predicted heart rate, or even 80–85% of the maximum predicted heart rate. We all of us miss the diagnosis of chronotropic incompetence because we examine the patient when he is lying on the couch or sitting in front of you. If you allow him to walk into the corridor or to climb the stairs, you will find he is unable to build a fast heart rate. And that might be responsible for his fatigue, for his effort intolerance, and so forth. Another manifestation of sinus node dysfunction is a tachybrady syndrome, When the patient is having tachycardia, usually atrial fibrillation, the heart rate is too fast. And when the patient suppresses his sinus node, the heart rate is too slow. Now, under all these circumstances, you should keep in mind etiologies that are by and large reversible, like drugs, metabolic disorders, hypervagotonia, carotid sinus syncope, and at least in the States and in some areas of the world, 50% of permanent pacemaker implants are in patients with sinus node dysfunction. Now, if we move into AV block, it can come into first degree, second degree, or third degree. Actually, we have 6 varieties of heart block. First degree block is actually a first degree AV delay. It does not produce bradycardia because all the atrial impulses are transmitted, but with a delay to the ventricle, with a long PR interval exceeding 200 milliseconds. If it exceeds 300 milliseconds, then almost always the conduction defect is in the AV node. That's an important trick. If it's too long, you think of AV nodal block rather than His-Purkinje block. The second degree can come as a Mobitz type 1 or Winkelbach, progressive prolongation of the PR interval and then a dropped beats. A benign condition can be present in normal athletes or during sleep and doesn't usually require a pacemaker except under very exceptional circumstances. And then Mobitz 2, in which the block occurs in the His-Purkinje fibers usually, and this is without, there is no prolongation of the PR interval, but there is sudden drop of one of the impulses coming from the atrium cannot be conducted to the ventricle. And this is usually a distal type of block, and it's quite unstable, and it can pass easily into complete heart block. It's usually associated with a lower pacemaker stimulation with wide QRS complex, but not always. And then 2-to-1 heart block, which can be either proximal like Winkelbach or distal like Mobitz 2, more proximal than distal. And then missed on this slide is advanced degree of second degree heart block, and advanced degree is 4-to-1, 3-to-1, 5-to-1, and so forth. And then we can get complete AV dissociation with the V's less than the A's, a third degree heart block. It's very important not to rush and implant pacemaker in every condition of heart block. You have to look for reversible causes and specific causes that are treated otherwise, including Lyme's disease. Remember, Lyme's disease has been repeatedly described in Egypt. So you don't need to be from Connecticut to diagnose Lyme's disease. Many groups of the parasitology departments in several Egyptian universities describe the Lyme's disease with the intermediate host, essentially the street animals. You can get it from acute myocardial infarction, and you can get it, as we mentioned before, from sarcoidosis. In patients with sarcoidosis, if you feel that you need a pacemaker, you usually implant a defibrillator, because I told you before that patients with sarcoidosis are prone to heart block as ventricular arrhythmias. In acute myocardial infarction, the occurrence of heart block, as everybody knows, depends on to a large extent on the site of the infarction. So in patients with anterior myocardial infarction, if you get the high-grade AV block, you are really sick. The block is in the His-Purkinje fibers and is associated with extensive septal infarction. Even if the block is transient, there is a high risk of recurrence. This is unlike the situation of inferior myocardial infarction, where the block is usually in the AV node. In the first 24 hours, it has a strong vagal component and is likely to respond to atropine. After the first 24 hours, it's unlikely to respond to atropine. It's usually related to edema in the infarct zone or ischemia in the infarct zone, and it might be adenosine mediated and responds to xanthine derivatives. It may be transient, and when it's transient, usually it resolves into within a week or 5 to 10 days. and there is a low risk of recurrence. Now, the money is actually for the diagnosis of heart block is in the His bundle electrogram. I hope we are joined by Professor Ahmed Al-Damati, and but I will allude to the fundamentals of these things, and he can detail on it later on. So if you look into the electrocardiogram, the P is corresponding to the atrial activation in the His bundle electrogram, which is displayed by an electrode put across the septal leaflet of the tricuspid valve opposite the His bundle. And then corresponding with the QRS, you will have the V wave, and in between you have the H wave corresponding to activation of the His bundle. The AH interval normally is 60 to 125 milliseconds, and the HV interval is usually between 35 and 55 milliseconds. The AH interval corresponds to the activation or the passage of the impulse in the AV node essentially, and the HV interval corresponds to the activation of the His-Purkinje system. If the HV interval exceeds 70 milliseconds, you start to worry, and if it exceeds 100 milliseconds, then it needs a pacemaker, 2A indication. Now, if you look into the normal conduction, there is an A and an H and V. Here we have an A, and here you have an A, and you don't have a V, so there is heart block. And that in this condition, there is no H, so the block here is proximal in the AV node. In this tracing, you have an H here, so the block here is distal to the AV node in the His-Purkinje fibers. This is unstable condition, progresses to complete heart block, and needs a pacemaker in the large majority of cases. Now, if you look into this electrogram, you have lead 1, you have AVF, you have V1, 3 perpendicular leads to each other. But if you look into the intracardiac His bundle recording, the HV is prolonged, it's 95. But if you complete the tracing, you will find that here in the electrogram, there is a P wave and there is no QRS, so there is a form of heart block. Now the money is in the His bundle recording, there is an H and a block. After the H, there is no V activation. So this is a conduction defect distal to the AV node in the His-Purkinje fibers. That's a serious situation and a strong indication for pacing. Now, temporary pacing is indicated for any symptomatic or hemodynamically significant bradycardia unresponsive to drug therapy. It's indicated for third-degree heart block if the ventricular escape rhythm is less than 40 beats per minute, or if there is a wide QRS escape rhythm. Patients with drug, not hereditary, with drug-induced torsade de pointes, as we pointed last time, are bradycardia dependent. You need temporary pacing to accelerate the heart rate, so to obviate the dispersion of the QT complex intervals. And you need it in high-risk patients with acute myocardial infarction. Actually, temporary pacing in acute myocardial infarction, the guidelines is very liberal because of the unstable situation. In contrast to the indication of permanent pacing in acute myocardial infarction. So if you look into these indications of temporary pacing in acute myocardial infarction, it includes almost everything more than single fascicular block or first-degree block. So it's the same indication which has been indicated in the 2004, 2012, and 2018 didn't change because there is no much research in this area. So you get a temporary pacing indicated if there is symptomatic bradycardia, if there is newly acquired or age-indeterminate bundle branch block, if there is an old bundle branch block and a new fascicular block. Obviously, if there is alternating left and right bundle branch block, this is a serious situation, so you need a transvenous pacing because it's more stable than the transcutaneous pacing. You need a transcutaneous pacing if you have an old bundle branch block and first-degree AV block, an old or new fascicular block with first-degree block, type 1 second degree AV block and type 2 second degree AV block and complete heart block. Obviously, you need a transvenous pacing under these circumstances. Now I move to the pacemaker code. It has been modified a little bit in the last decade. The original code, it was composed of 5 letters. Now we used 4 letters only. The 5th letter is now a description for the ICD and has been removed completely from the description of the pacemaker. The first letter corresponds to the chamber pace, V for ventricle, A for atrium, D for dual, and O for none. And the second is the chamber sensed, again the same, V for ventricle, A for atrium, D for dual, and O for none. And the third is the response of to sensing, triggered if you have an impulse in one chamber, triggers the impulse in the other chamber, inhibited or dual or none. And the fourth letter is actually R. All of this has been removed completely because all the pacemakers available now are multi-programmable and they are communicating. So they are rate responsiveness or not rate responsive. So we have 3 letters and an R occasionally, and we don't have the 5th letter, which is now a description for the ICD. Now let us spend some time about the timing of the pacemaker, which is a very important subject. Now in the VVI, which is a ventricular inhibited pacemaker, we program something called the lower rate limit. The rate beyond which the patient goes with his native rhythm, and under this rate starts to pace. So here we have an ECG, and here we have a ventricular electrogram. There is no atrial electrogram because this pacemaker does not contain a lead in the atrium. It contains one single lead in the ventricle. So here this complex is a junctional complex or a ventricular event sensed by the pacemaker. There is a timer in the pacemaker which brings the timer to 0 when it senses anything, and then it starts to count 1000 milliseconds. Where did we bring the 1000 millisecond? 60,000, which is the number of seconds in one single minute, divided by the lower rate limit, which is 60, is 1000. So if there is 1000 milliseconds elapses, if nothing is felt during this period, then the pacemaker throws a spike and paces the ventricle. Now here there is an atrial event. Obviously, the pacemaker will not feel this atrial event because there is no atrial lead. And then after this spike, the pacemaker timer will come down to 0 and start to count 1000 milliseconds. But after 800 milliseconds, there is a junctional beat felt by the pacemaker lead in the ventricle, which brings the V timer to 0 and then starts to count 1000 milliseconds. Nothing happened. There is an electrical activity in the atrium, not sensed because there is no lead in the atrium. And then we get a spike and pacing the ventricle. And then after that, the pacemaker starts to count to 1000 milliseconds. And after the 1000 millisecond will throw a spike. But at this time, another junctional complex was felt by the pacemaker. So it stopped at 850 milliseconds and brought the V timer to 0. So as you see here, the pacemaker in VVI always paces at the lower rate limit, never exceeds that. This is in contrast to the situation with the DDD pacemaker, which has a tracking function, and it tracks the atrial activity, and it doesn't have one clock like the VVI pacemaker. It has 2 clocks. It has a clock which indicates the AV clock, which corresponds to the PR interval, and it has another clock which is a VA clock, or the atrial escape interval, which is the interval that elapses from the sensed or paced ventricular activity to the next atrial paced activity. It has an up
محمد هو الصوت قطع من عند حضرتك. محمد حضرتك سامعنا؟
To this is the dual chamber pacemaker. At the top here we have an ECG. In the middle we have an atrial electrogram because this is a dual chamber pacemaker. And below it you have a ventricular electrogram. Here we have a sensitive ventricular event. We program a lower rate limit here as 60 beats per minute. We program an upper rate limit depending on the age of the patient and the comorbid conditions. Here we programmed 820. We programmed something called the PVAR, or the post-ventricular effective refractory period, or as they call it frequently, post-ventricular atrial refractory period, programmed in this person as 250 milliseconds, and we program an AV delay of 200 milliseconds. Here there is a ventricular impulse sensed by the pacemaker, brings the V timer to 0. Then we started to count 800 milliseconds. Where did we bring the 800 milliseconds? This is a lower rate limit of 60. So the VV interval is expected to be 1000 milliseconds as we mentioned before, but we have an AV delay of 200 milliseconds. So 1000 minus 200 milliseconds is 800 milliseconds. So after 800 milliseconds, nothing is felt by the pacemaker, atrial or ventricular leads. So there is a pacing of the atrium. After pacing into the atrium, the AV clock starts to work, counts 200 milliseconds, which is the AV delay. If nothing is felt, we throw a spike and we pace the ventricle. After we pace the ventricle, the ventricular timer goes down to 0. And then we started to count 800 milliseconds to activate the atrium. But here an atrial event occurs. Whether this is a sinus beat or an atrial premature beat, it happened after 600 milliseconds. So it is sensed by the atrial electrode. It brings the atrial electrode to 0, the AV clock to 0, and starts to count 200 milliseconds, which is the AV delay. Nothing is felt by the pacemaker, so it throws a spike and activates the ventricle. Now, after that, the VA timer is brought down to 0 and starts to count 800 milliseconds. After 600 milliseconds, another atrial activity is sensed, brings the V timer to 0 and starts to count 200 milliseconds. But before the lapse of the 200 milliseconds, a ventricular impulse has been sensed because this atrial activity has been conducted through the normal AV conduction, felt by the pacemaker, brought the V timer to 0, and starts to count 800 milliseconds again. Nothing happened, so there is a pacemaker spike activating the atrium, and then before the lapse of 200 milliseconds, which is the programmed AV interval, we get conduction of the next of the QRS complex through the native conduction system. So as you see here, we have 4 complexes. The 4 complexes, all of them represent normal dual chamber activity. We have here pacing in the atrium and pacing in the ventricle, sensing in the atrium and pacing in the ventricle, pacing nowhere because we are sensing the atrium and sensing the ventricle, and here we are pacing the atrium and sensing the ventricle. All of them are normal. An important point here, if you look to this cycle is 600 milliseconds. So it's for the first time we are pacing here at more than the lower rate limit. In VVI pacemaker, we can never pace more than the lower rate limit. But because we are tracking the atrium, if the atrial activity is faster, then we tracking the atrium will result in pacing the ventricle at more than the lower rate limit. Now, having said that, we look into a more complicated situation. Here again, we are pacing in the atrium, and then 200 milliseconds, nothing happened. Then we throw a spike into the ventricle, brings the V timer to 0, and starts to count 800 milliseconds. After 800 milliseconds, before the lapse of the 800 milliseconds, we felt an atrial activity sensed by the atrial electrode, and then we started to count 200 milliseconds, which is the AV interval. Nothing happened. We throw an impulse here and activate the ventricle. But here the person went into atrial fibrillation. It's unphysiological to feel the atrial fibrillation during the PVAR, the post-ventricular effective, or as they call it, atrial refractory period. So here it's conducted, it lasts here is 250 milliseconds. Nothing is felt because this is blanked out. Immediately after the 250 milliseconds, we started to feel the fibrillation wave. So at 260 milliseconds, the atrial electrode felt the fibrillation waves. So it's going to count from here 200 milliseconds, which is the AV delay, and throw a spike. But wait a minute. If you have 260 milliseconds, which is the PVAR, and 200 milliseconds, which corresponds to the AV delay, this equals 460 milliseconds. 60,000 divided by 460 milliseconds is 130 beats per minute. But this exceeds the upper rate limit, and the pacemaker cannot violate the upper rate limit. So it has to prolong the PR interval here and delay the conduction to the ventricle more than the AV delay in order to keep in the upper rate limit in the correct way. So under these circumstances, you can see that there is an obligatory delay in ventricular activation after sensing the atrial activation. As you increase the atrial rate, this delay can transform from first degree delay, which is a delay in the AV junction, or into a pseudo-Winkbach, into a 2-to-1 block. All of these are normal activities for a dual chamber pacemaker. Now, as you see here, it's important to understand these things. If you look into the PR interval, the PR interval is divided into 3 components. It's divided into an early 100 milliseconds or so, which is the absolute blanking period. The absolute blanking period is a period in which the ventricle cannot sense the atrium. One chamber is completely blind to the other. This in order to avoid sensing the atrial activity into the ventricle and therefore producing a crosstalk. If the ventricle senses the atrial activity, then he probably understands that there is ventricular activity and does not pace. So this is the reason we have in the initial part of the AV interval, the absolute blanking period. After the first 100 or 120 milliseconds, there is another period called the safety pacing period. In this safety pacing period, if the ventricle senses an activity, it paces one beat. So it avoids again the occurrence of crosstalk. So crosstalk is obviated by 2 intervals. The 2 intervals is the absolute blanking period in the initial part, and this follows a sensed or a paced atrial activity, and then a crosstalk window with safety pacing, which occurs only when we are pacing the atrium, we are not sensing the atrium. And then the last part of the AV interval is the 3rd component, which is an alert period in which a ventricular activity is not sensed at all, to give a space for the natural ventricular activity or the paced ventricular activity to occur. Now we move from this to the pacemaker leads. Actually, we have 2 varieties of leads. And recent pacemakers, you can change the bipolar lead into unipolar lead under certain circumstances. The unipolar leads, you have the cathode at the end of the electrode, and it's located in the ventricle or in the atrium. it's pacing under the trabecula of the ventricle or in the atrial appendage or somewhere in the atrium. And because the electrons have to go somewhere, it goes to the pacemaker can, which is a titanium can, hermetically sealed and containing the components of the pacemaker. And because this is a large window, it senses many of the structures in between, including pectoral muscle activity and so forth. And because of the large span of this window, it has a prominent spike. So the spike is prominent, clearly seen, and oversensing is common. This is in contrast to patients with bipolar pacing, which are more frequently used nowadays, in which the cathode is located at the end, and just a few millimeters proximal to it, there is the anode, and the electrons pass between the cathode and the anode. It has nothing to do with the pacemaker. It's a more complicated, but it allows the display of a small or a short pacing spike, and there is no oversensing from an external activity. Now, the pacemaker leads are usually fixed either by active fixation like this tiny screw which is present here. The only disadvantage is that it can perforate, particularly when it's attached to the atrium, but it has a lot of advantages. One of the advantages is that it can be more easily removed than the passive fixation with the stines or fines here, which are made of silicone or polyurethane. They are insinuated below the trabecula, and it looks like a miracle that they can fibrose within few weeks or months. And sometimes if they remain for a year, it becomes very difficult to remove them. Removal of the leads is important, particularly if there is any infection, and it's not an easy process. There is a lot of inventions like snares, like cutting sheaths, or sheaths supplied with laser energy, or electrosurgery. Now this is the strength duration curve, and I'd like you to concentrate with me. This shows the relation between the duration of the pulse impulse or the pulse width and the stimulation threshold in volts. And if you look here, as you go into infinity with the pulse width or a very wide pulse width, the threshold, the activation threshold in volts is called the Rayo base. So the Rayo base is a stimulation threshold. If you double the Rayo base, and you jump here, double the Rayo base, and then look at the time at which the Rayo base consumes to activate, this is called the chronaxy. And the chronaxy is the ideal time to pace the heart, ventricle, or atrium in order to save the battery power. So, usually the manufacturer supplies you with a chronaxy in the range of 0.4 to 0.6, or on the average 0.5 millisecond. And most of the implanters usually use the manufacturer pulse duration. But this is the scientific basis of choosing 0.5. It's the chronaxy, which is the time required for double the Rayo base to capture. You like to be up here, because anything above this line is likely to capture. You don't like to be down here. If anything below this line of the strength duration curve, it's not likely to capture. So it's very important to understand this part. Now we move from capturing into sensitivity. It's a programmable function of the pacemaker. If you put the sensitivity is the ability of the device to see the different complexes. We like for the device to see the QRS and not to see the P wave or the T wave. Now, if you program the device so very sensitive, that the sensitivity is low here, then it's going to sense everything. So it's going to sense the T wave as well as the QRS complex, and the pacemaker does not distinguish between this, so it's going to double count the heart rate. But if you put the pacing threshold into a higher number, that's a low sensitivity, it's not going to sense anything. So we put it here in the middle, like something like 2.5 millivolt, under these circumstances, it will not sense the T wave, but it will sense the QRS. Now we come to the fourth letter, which is R. This R corresponds to rate responsiveness. It's usually chosen in patients with sick sinus syndrome, whether we are using a DDDR or atrial pacing AAIR, and it's in patients with the permanent atrial fibrillation or long-standing atrial fibrillation, you cannot pace the atrium, so there is no point in putting an electrode in the atrium. So we use a VVIR, which increases the heart rate during exercise. How the pacemaker knows that you are exercising? Well, the commonest way is vibration. There is a piezoelectric cell which is welded to the inside of the can of the pacemaker. If you vibrate, it increases the ventricular pacing. And you can vibrate more when you are going down the stairs than you are going up the stairs, although you need more energy in going up the stairs. So as a result of that, other forms of in accelerating the heart rate, including respiration, by shooting a small amount of current to measure the impedance across the inflated lungs. And if you get a decrease in the impedance, this increases the heart rate, or a temperature sensor. Some devices, they measure the QT interval and use it as a sensor. And some devices, they can calculate the amount of contractility around the pacemaker tip. All of these sometimes can be used in combination, which is more effective than using an isolated parameter in order to increase the heart rate. Which heart rate is increased by this? The lower rate limit. Now, the guidelines is very important. They didn't change over the years since 2011. It's very important. They are worthy. Some of you may consider it monotonous, but it's very important, and you have to revise them before setting the examination. For sinus node dysfunction, class 1 indication is symptomatic bradycardia. So if you have symptomatic bradycardia, including frequent sinus pause, that's class 1 indication for permanent pacemaker. If you have symptomatic chronotropic incompetence, or if you require drug therapy that is essential for treatment of the patient, like slowing rapid atrial fibrillation, and this results in symptomatic bradycardia, you cannot stop the drug, then you need permanent pacemaker. And 2A, a sinus node dysfunction with a heart rate less than 40, even if there is a clear association between the symptoms and the occurrence of bradycardia, is not clearly documented. Or if you get syncope, and this syncope is unexplained by the occurrence of the heart rate, the patient is in the CCU, he has heart rate of 40, but he is getting recurrent syncope, so you assume that it gets under normal circumstances less than 40, and the patient gets syncope. This is a 2A indication for pacemaking. The indications is slightly more complicated in patients with complete AV block. Class 1 indication is third degree or second degree AV block at any level associated with bradycardia with symptoms, or as a result of the bradycardia, you are getting ventricular arrhythmia, which is related to the occurrence of the bradycardia. Or if you get a third degree or advanced second degree AV block with any of the subsequent 5 events. Number 1, symptomatic bradycardia. Number 2, if you get third degree or advanced second degree AV block with sinus rhythm, but the patient is having symptomatic asystole for 3 seconds or more, and an escape rate less than 40 beats per minute. And number 3, if the patient is having atrial fibrillation with pauses of 5 seconds or more. If the patient is getting atrial fibrillation with 5 seconds or more when he is sleeping, this is not an indication for pacemaker. This is an indication for adequate rate control. The patient should be awake, whether he is in sinus rhythm with a pause equal or above or more than 3 seconds, or in atrial fibrillation with pauses equal or more than 5 seconds while awake. Obviously, the third thing, if you get AV nodal ablation, you need a permanent pacemaker. Again, number 4, a third or advanced degree, second degree AV block, which is associated with a post-operative AV block that is not expected to recover. Usually, post-operative AV block recovers after surgery. Under exceptional circumstances, it doesn't. So this is an indication for permanent pacemaker. And the last thing among the 5 with third degree and advanced second degree AV block, if you have a myotonic dystrophy, because these are progressive conditions, so under this circumstance, you need a pacemaker. So back again to the rest of the class 1 recommendation, persistent third degree AV block with an average heart rate more than 40, but there is a cardiomegaly or evidence of left ventricular dysfunction, or if there is evidence from electrophysiological study that the block is below the AV node. You get an H, you don't get a V. Or a second or a third degree of heart block that's produced by exercise in the absence of ischemia. If there is evidence of ischemia, then you correct the ischemia. This is an exercise-induced paroxysmal AV block. There are several theories for that, but I will read this for another discussion. For class 2A, persistent third degree AV block with an escape rate more than 40 in asymptomatic adult, but unlike the situation with the first degree, there is no evidence of left ventricular dysfunction or cardiomegaly. Or if you get second degree AV block with intra or infra-His block, so you get an H or a split H in EP study. Or if you get first degree, this is the first time we mentioned first degree or second AV block, but the PR interval is so long that it falls on the preceding QT interval and it produces manifestations similar to the pacemaker syndrome. You get contraction of the atria against the closed AV valves, the atrial pressure rises, produce congestive manifestations, throbbing in the neck veins, hypotension, elevation of BNP, which produces vasodilatation and syncope. Or if you get asymptomatic type 2 second degree AV block with a narrow QRS, this is very rare, but it happens, and if it happens, it is a 2A indication for pacemaker. For bifascicular block, if you have type 2 or advanced second degree or intermittent third degree with bifascicular block, this is an indication. And obviously, if you have alternating bundle branch block. And it's 2A, if you get syncope when other causes have been excluded. So the patient has syncope, you take him to the EPS, you induce ventricular tachycardia. There is no ventricular tachycardia, but he is having bifascicular block. So you assume that he is getting more complete heart block responsible for syncope, indication for pacemaker with a concept of 2A indication. Or if there is an incidental finding during APS, the HV, as we indicated before, is more than 100 milliseconds, equal or more. Or if you physiologically pace the atrium at a rate of 120 or less, and as a result of that, you get an infra-His block, this is again an indication. Now, in patients with acute myocardial infarction, you remember the temporary pacing is very liberal, but here is very conservative. Or a bifascicular block, or even a trifascicular block, you should get some form of AV block. So it's indicated class 1, permanent ventricular pacing is indicated for persistent and symptomatic second or third degree AV block, or persistent second degree AV block in the His bundle His Purkinje system, or third degree AV block within or below the His Purkinje system, or a transient second or third degree infranodal block associated with bundle branch block. If the site of block is not certain, you do an APS. So always you should get a form of AV block and not just a bundle branch block or a fascicular block. Carotid sinus hypersensitivity, you should get syncope whether this syncope is occurring spontaneously associated with ventricular asystole more than 3 seconds, or you get it provocable by compressing or rubbing the carotid sinus and producing a 3 second or longer a cardio-inhibitory response. Having said that, we move into the second question. A 90-year-old woman comes to your office for a pacemaker check. Her pacemaker is found to be working perfect. Her sensing and pacing parameters are excellent and stable. Her pacing impedance is normal and has not changed from previous values. The lower rate is set at 60 beats per minute, and the electrocardiogram is shown here. I hope that shows, but I will help you. You'll find that this is a P wave and P wave, and this atrial rate here is 80. And there is here a 2-to-1 block, not a complete heart block. So as a result of that, the ventricular rate is 40. Remember, the lower rate limit was 60. So the question is, if her pacemaker is indeed functioning normally, to which of the following modes the pacemaker is programmed? AAI, VVI, DDD, VET, or managed ventricular pacing? And I will tell you what's there. Now I'll go back to the electrocardiogram and tell me what is the mode of pacing in this patient. Obviously, you don't find any pacing spikes here. So what happened here? We are putting the pacemaker at 60 lower rate limit. Here, the atrial rate is 80. So there is no pacing in the atrium because the atrium is the native atrial rate is higher than 60. So there is no need for the pacemaker to work. So there must be an electrode in the atrium that's recognizing that the atrial rate is above 60. So there must be an electrode in the atrium. Now there is no pacing in the ventricle. So there is no electrode in the ventricle. Otherwise it will recognize that the ventricular rate was slow and paces the ventricle. So the pacing mode here should be an AAI. The AAI here is not pacing the atrium because the atrial rate is more than the lower rate limit, and is not knowing what's happening in the ventricle because there is no ventricular lead to inform the pacemaker about the ventricular events. So it's an AAI. So as you see here, you are not doing anything for the patient. The patient is unprotected, and this is the reason we are not putting too many AAI, although it has a lot of advantages, as I will point out. Now, what are the common pacing modes and how we select them? VVIR, there is no significant atrial contribution. It's generally chosen for permanent or persistent or long-standing atrial fibrillation with bradycardia. If you have a patient with VVIR pacemaker and he was tolerating it well without any problem, end of life came, and you want to replace the pacemaker, you can put another VVI. If the patient is an elderly individual with limited activities, lot of comorbidities, again, you require to insert a VVIR. It's a simple, quick, rapid, single lead insertion. Now, if you think of VVIR as the appropriate mode of pacing, nowadays you might think about transcatheter delivery of the leadless pacemaker. Leadless pacemakers, now we have a lot of varieties, a variety of leadless pacemakers. They are inserted transfemorally through the sheath. Their length varies between 2.5 to 4 centimeters, and they can function without having a lead. The weakest point in the chain of pacing is the pacemaker lead. Now, AAIR is commonly used in patients with sinus node dysfunction, provided that there is no evidence of AV nodal disease or Hesper-Kenji disease. Under these circumstances, we use AAIR. In modern pacemaker, there is a function called the managed ventricular pacing, in which the pacemaker every now and then check the AV conduction. And so long as the AV conduction is intact, it paces the atrium. In this condition, it ensures that the ventricular pacing will not be pacing through at the apex of the right ventricle. Pacing in the apex of the right ventricle produces a left bundle branch block and eventually results in ventricular dysfunction and aggravates the occurrence of heart failure and the occurrence of atrial fibrillation. So managing ventricular pacing tries to avoid that by choosing the pacing of the patient through the AIR. The problem is the patient might having an AV nodal disease, and if he is pacing AIR with an AV nodal disease or his Purkinje disease, he is unprotected. So managed ventricular pacing periodically checks the AV conduction, and so long as the AV conduction is intact, it paces the atria. If it feels that the AV conduction is impaired, it changes from AIR into DDDR. So this is the pacemaker which is commonly used for patients with a heart block, and R is used for chronically incompetent patients. Now we have mode switching, and this mode switching is whenever the atrial rate is accelerated, we stop tracking the atrium. So if the atrium went into atrial flutter, supraventricular tachycardia, or more commonly atrial fibrillation, we stop tracking the atrium. So we change from DDD into DDI, in which we do not track the atrium, not VVI, because if it is VVI, how the pacemaker knows that you went back to sinus rhythm? In VVI, there is no atrial electrode, so it cannot know that you went back to a sinus rhythm. That's why mode switching, it changes DDD into DDI rather than VVI. Now, what's the negative impact of right ventricular pacing? This is actually a study called the David study. It's not a pacemaker study, it's a defibrillator study. More than 500 patients has been randomized into pacing in the VVI mode. In the VVI mode at a rate less than 40, or in the DDR mode at a rate less than 70. So as you see here, if you pace at a rate more than 70, you are likely to pace more frequently with this mode than if you wait until the heart rate drops below 40. So actually, pacing here, the ventricle was more frequent than pacing the ventricle in this mode. So as a result of that, after a follow-up period of several months, it turned out that the primary endpoint of mortality and hospitalization for congestive heart failure was more with the more frequent ventricular pacing. So at 1 year, it's 16% of patients with VVI versus more, 27% with DDI, which led to termination of the trial. So as a result of that, we know that if you pace the ventricular chamber, you create a left bundle branch block, you impair the synchrony of ventricular activation, you get increased mortality and increased hospitalization. And what is missing on this slide is that you could increase in the occurrence of atrial fibrillation. So the mechanism is the adverse right ventricular remodeling and left ventricular dysfunction, which occurs by the creation of left bundle branch block. So as a result of that, modern pacemakers try to avoid that by doing two tricks. AV search hysteresis by prolonging the AV interval. And if you prolong the AV interval, you allow the native conduction with a shorter PR interval, or the managed ventricular pacing, which I just explained, by every now and then checking the AV conduction, and once it is intact, you allow AAI pacing rather than DDD pacing. Third question. 75-year-old man comes to your office for routine pacemaker check. Is feeling well without complaints because your office manager failed to pay the electric bill for the last 3 months. Electric power was cut off in the office in the middle of the visit. You are unable to use the pacemaker interrogation system. The ECG is available for examination, and his pacemaker was always been set for a DDT, lower rate 60, upper limit 120. So this is the ECG. I hope it shows very well, but I will explain it. You will find here the native P wave, then a spike and pacing from the right ventricular apex. ايوه يا ياسر.
يا دكتور محمد حسن حضرتك، هو الصوت قطع وحضرتك بتشرح الاي سي جي.
معلش I will show you the ECG again and approaching the end now, and it's appropriate. Is the ECG, I will show it again, but is the pacemaker is making appropriate atrial capture and atrial sensing for ventricular capture and ventricular sensing, or appropriate atrial capture and ventricular sensing for appropriate atrial capture and ventricular capture for appropriate atrial sensing and ventricular capture. Now back to the ECG. Now back to the ECG. Now the lower rate limit here was 60, but the atrium here is more than 60, so it's not being paced. But every atrial impulse is being sensed. There is no spike before it, and then the AV interval is being 100 to 200 milliseconds, and then there is consistent ventricular capture. So here we are pacing the right ventricular apex, producing a left bundle branch block. And as you see here, it's atrial sensing and ventricular capture. What about ventricular sensing? You cannot examine that because there is no native beat to know whether it's ventricular sensing or not. So the correct answer here is atrial sensing and ventricular capture. Now, how you evaluate a pacemaker? 5 steps. One step is missing from this slide. The first question you ask is the pacemaker is pacing, and you know that by finding a spike. If you don't find a spike, you put the magnet. If if the spike appears, then this means that there is electromagnetic interference or there is a crosstalk. Then the second question, is it sensing? Is it sensing the ventricle and sensing the atrium? Is it capturing? Is it capturing the ventricle or capturing the atrium? Number 4, is the rate appropriate? And number 5, what is the problem? The problem can be under sensing, over sensing, non-capture, and pseudo malfunction. And I will go through this. This is an example of failure of capture. You get a pacemaker spike here, but there is no ventricular capture. And you get a pacemaker spike in the atrium here, and there is no atrial capture. Where is the problem? It can be in the can, it can be in the screw, it can be in the lead, or it can be because of a high threshold for capturing or dislodgement that can be seen radiologically, or a micro dislodgement which it can not capture but cannot be seen radiologically. And then we have oversensing. Oversensing is detected by the presence of a slow heart rate. You cannot know that there is oversensing unless you apply the pacemaker analyzer, a programmer, and then you will find that there is here the marker channel shows that you are ventricular sensing, ventricular sensing, ventricular sensing. There is nothing here to be sensing, so this must be something external. It can be something external like myopectoral activity, or it can be a part of the electrogram like feeling the T wave, or it can be an electromagnetic interference that I will come to shortly. Now again, the problem here can be in the can be in the lead, can be in the contact between the lead and the ventricular myocardium. Under sensing, you get pacemaker spikes here where it should not be present. It didn't see here this complex, so there is a spike delivered during the post-ventricular atrial refractory period. Again, under this in this speed, didn't see this speed, so this is under sensing. Now, or you can get pseudo malfunction. What is pseudo malfunction? Is ECG findings that appear to the result of pacemaker malfunction, but actually the pacemaker is normal. There are two common examples for that. Pacemaker mediated tachycardia, which is a reentrant arrhythmia in which there is dissociation between atrial and ventricular activity, like for example the occurrence of a PVC or a sudden interruption of atrial capture. As a result of that, the PVC will be conducted retrogradely to the atrium, sensed by the atrium since it falls outside the post-ventricular atrial refractory period, and then goes back, sensed by the atrial electrode, and then goes to activate the ventricle. Under these circumstances, you get a pacemaker ventricular tachycardia pacing with an upper limit corresponding to the upper rate limit. Now, this is different from pacemaker tachycardia. Pacemaker tachycardia includes pacemaker mediated tachycardia, and this includes as well if you have a pacemaker tracking a rapid atrial rate, that's pacemaker tachycardia. And the third situation, if R is producing excessive vibrations or excessive rate responsiveness, so you get acceleration of the ventricular pacing as a result of that. But specifically, this is the pacemaker mediated tachycardia, is called endless loop tachycardia. It's a reentrant tachycardia with the retrograde limb across the AV node and the anterograde limb across the pacemaker and the ventricular electrode. Now, hysteresis is a method of saving the battery life. Under these circumstances, if the patient lower rate limit set, for example, at 40, then he starts to pace at less than 40, say 39. But when it paces at a higher rate like 60. Sometimes in patients with carotid sinus syncope or patients with vasodepressor syncope, we pace these patients with the cardio inhibitory component, and we pace at a rate of 100 until the patient regains consciousness, and then we fall back the pacing rate. Now, how you treat pacemaker-mediated tachycardia? Obviously, you open the reed switch, which is responsible for sensing the atrial activity by applying a magnet. That's in the acute situation. But chronically, the easiest method is to prolong the P-bar, which is the interval in which the atrium is blinded for retrograde ventricular passage of the impulse, or you can stop the re-entrant circuit by applying some drugs to block the AV node, or you can use certain algorithms, like, for example, periodically increasing the post-ventricular atrial refractory period. If you get a PVC, then the pacemaker device automatically increases the P-bar for one cycle. If you get a tachycardia, then the pacemakers can interrupt the tachycardia by increasing the P-bar for one cycle and stop it. Or you can change the mode. You rarely resort to that. You can change the mode of the pacemaker into a VVI, so you avoid sensing the atrial of the retrograde reactivation. Now, the magnet operation, if you apply the magnet for the pacemaker, it changes into a synchronous pacemaker. And VVI changes into VOO, and the DDR changes into DDO. When the pacemaker lifespan approximates the end, then usually the pacemaker changes into a simpler form. You can check that by the magnet at the early on, and in an old way of knowing the life, what remains of the battery, is to apply the magnet, and you get the heart rate with the magnet applied on the pacemaker. And for every company and every specific pacemaker, there is a certain heart rate called the magnet rate, and it was used previously to indicate how much of the battery is left. Now, electromagnetic interference is an important subject. Actually, the hospital environment is the worst environment in which the patient can live with a pacemaker, because the hospital contains electrocautery, cardioversion, defibrillation, magnetic resonance imaging, lithotripsy, radio frequency ablation, ECT therapy, diathermy, and TENS, which is the nerve stimulation, transcutaneous nerve stimulation. And outside the hospital, wireless telephones, electronic articles, and surveillance equipments, if they are out of order. So under these circumstances, these conditions should be looked for. In electrocautery, we get too many consultations from the surgeons about the use of electrocautery. It can be used safely if you use bipolar electrocautery, if you keep away from the pacemaker can, and if you use it episodically, not continuously. So these are the 3 points of advice that we give to our colleagues, the surgeon, to avoid problems from using the electrocautery. Same applies to lithotripsy and other situations. One problem of pacing is phrenic capture, whether by the atrial electrode or by the right ventricular apical electrode or left ventricular transvenous electrode, which is used in CRT. They can stimulate the diaphragm directly or indirectly through the activation of the phrenic nerve. That's why the implanters usually test for that during the procedure by applying a pacing energy of at a higher level, 10 millivolt or so, and making sure that the diaphragm is not contracting. If it contracts, it produces hot hiccup or allows the patient to jump. Miraculously, some of the patients, they have it and they don't complain of anything. But one has to be on the lookout of that. Under these circumstances, you reduce the output of the pacemaker, but rarely you need to change the electrode from touching the phrenic nerve or touching the diaphragm. Pacemaker infection is a big problem. Unless you have a very superficial incisional infection, then you have to remove everything. For the superficial incisional infection, you might try antibiotics for a week or so, but always, you have to get everything out. Pacemaker infections can be in the form of a pocket abscess or erosion of the skin, or you get a septicemia. The treatment is to remove the entire system, and at the same time, you can get the pacemaker jacket during that period, or you can put the patient in the ICU until everything is sterilized, and then you put the new devices. It's very difficult to diagnose lead endocarditis because even transesophageal is not helping that, but everything should be got out. The risk of major complications is high under these circumstances, and the pacemaker lead extraction is not an easy thing. It can result in cardiac avulsion, in cardiac tamponade, in vascular tear, in pneumothorax or hemothorax, and sometimes even in pulmonary embolism. MRI is a potentially deleterious interactions with the pacemaker. It can inhibit pacing. It can result in asynchronous high-rate pacing. It can lead to heating of the tip of the electrode, or it can result in loss of capture. It's contraindicated in patients who are having all the models of pacemakers, but now we have most companies are having MRI conditional pacemakers. You wait for 6 months according to the guidelines post-implant. You make sure that there is no previous devices or broken lead. You put the pacing threshold at a reasonable level and make sure that the impedance is normal. And then you have a special mode called MRI mode, and it's applicable for 1.5 Tesla. Nowadays also is applicable for 1.43 Tesla. Now, what about the pacemakers which are non-conditional? If MRI is mandatory, then you should get an expert standby that programs, make sure that he's able to program the pacemaker after doing the MRI and be ready to implant a temporary pacemaker if the condition requires, and make sure that everything is in order before the patient leaves the MRI suite. So in summary, bradyarrhythmia can be caused by sinus node dysfunction or sinus or AV block. Treatment of bradyarrhythmia is essentially permanent pacemaker. VVI is the mode of choice if you have permanent or long-standing persistent atrial fibrillation with bradycardia. DDR is indicated for almost all other indications. Pacemakers are very sturdy and reliable. Pseudo malfunctions are more common than true malfunctions, and good understanding of how the pacemaker works and its timing allow you to troubleshoot when they fail. So I stop at this stage. I hope Ahmed Al-Damati is available so he can make any comments or talk about whatever he wants to talk about before we get the question. If Ahmed Al-Damati didn't come, then let's have the questions.
شكرا دكتور محمد.
عفوا حبيبي.
طيب منتظر بقى الأسئلة من الشباب بقى الموجودين.
أحمد دماتي ما جاش؟
أنا مش شايفه، أنا بدور على اسمه مش شايفه.
طيب ماشي، يبقى كل الكويشنز ليه. And I thought if he comes then he takes part of the questions, but it seems that he's busy.
في سؤال عن السودو وينك باخ، حضرتك ممكن تإلستريت السودو وينك باخ إيه؟
السودو وينك باخ احنا الفكره كلها انك الفنتريكولار بيس ميكر اللي هو of the DDD variety has the ability to track the atrial rate. If the atrial rate is rapid, then the pacemaker cannot violate the upper rate limit. فلازم يبقى بيبيس عند الابر ليت ليميت. فاذا تصورت ان اي رابيد اللي هي بي ويفز رابيد كل مره هتيجي at an earlier interval. So if it comes at an earlier interval, it will fall into the P bar. So as a result of that, وهي بتيجي البي ويف قريبه من الكيو ار اس بتاع البيس ميكر اللي بيبيس عند الابر ريت ليميت، هيحصل ان البي ار انترفال بتاعته تطول لانها بتقرب من البي بار and then gets blocked. So you get progressive lengthening of the AV interval and then a block. This is not a Wink-Bach because Wink-Bach is a native phenomena of the normal conduction. This is similar to Wink-Bach induced by failure of the ventricular activation to track the atrial activation because انك انت setting upper limit. وبالتالي اتسمى سودو وينك. اذا هو الاتريال ريت زاد كمان قام تتقلب من سودو وينك باخ الى 2 to 1. So خلينا عندي ارقام. افرض ان انا عندي upper rate limit 120. الاتريال ريت بتاعي اقل من 120 والكوندكت 1 to 1. الاتريال ريت بقى اتريال فلاتر او بقى سوبرا فنتريكولار تاكيكارد او مور كومنلي اتريال فايبريليشن، يبقى الاتريال ريت زاد. يبقى في الحاله دي هي عندي مور بي اكتيفيشن ذان في اكتيفيشن. نتيجه كده ايه؟ ان البي ويفز او الاف ويفز او فلاتر ويفز will come progressively closer للفنتريكولار اكتيفيشن. as it comes closer قام تبص تلاقي بيوصل بتطول البي ار انترفال. انا وريتكم لازم تطول البي ار انترفال عشان we don't violate الابر ريت انترفال. تفضل تطول لغايه ما تبقى الاتريال اكتيفيتد وقعت في البي بار نوت كوندكت. فبقى عندك progressive prolongation of AV interval followed by a dropped beat. This is the pseudo. اوكي الامبورتنس بتاعها انك انت لما تشوفها ما تقولش ان دي بيس ميكر مال فانكشن. هيزيتيت فيري ماتش انك تشخص بيس ميكر مال فانكشن اذا كان البيس ميكر متركب كويس وخصوصا متركب من مده عشان ما فيش تقول ان في ديسلوجي. اذا قال لك في الامتحان ان في بيس ميكر متركب اديله اسبوعين don't think of dislodging out of question.
طيب دكتور محمد، في سؤال تاني عن الانفيريور ام اي لما بيحصل كومبليت هارت بلوك، وبيسأل لو ما عرفش يعمل ريكاناليزيشن للكورونري يعمل ايه العيان؟ يستنى قد ايه لغايه ما يحط بيس ميكر؟ او ايه البروتوكول اللي يمشي عليه؟
خلينا اتكلم اقول كل حاجه عنه. Inferior myocardial infarction activates the vasovagal reflex, so it has a vagal component. لكن we are not sure ان الفيجال component ده هو سبب الديلي conduction. We don't الإجابة الصح خالص ان the mechanism of impaired conduction في الانفيريور myocardial infarction is not known. طب ايه اللي نعرفه؟ اللي نعرفه هو ما ياتي. ان اولا انه ريفرسبل، وثانيا انه بناين، وثالثا انه في ثيوريز هي اضعف الايمان. طيب ايه هي الثيوريز؟ في الغالب ان الفيرست 24 اورز في اكتيفيشن اوف ذا فيجال plexuses اللي موجودين في الكراكس بتاع الارت وفيزوفيجال ريفلكس. سو وي تراي اتروبين frequently it fails. طب وبعد ال 24 اورز الفيلير ريت اكتر لانها بتبقى due to edema and ischemia may be adenosine mediated. So sometimes methylxanthine or aminophylline can work. لكن حتى if nothing works, you can put a temporary pacemaker. You wait a week. Within this week, most of them they recover AV conduction, and you do not need a permanent pacemaker. كلنا عارفين ان sometimes you wait 10 days, you wait 2 weeks. لكن جرت العاده ان احنا مش هنخلي العيان في الانتنسيف كير لمده 2 weeks. So we wait عاده ما بين 5 ايام الى 7 ايام. By large majority عند ثالث او رابع يوم هيرجع النورمال AV conduction. Has nothing to do with the revascularization. Ischemia is a theory that has not been proved.
الدكتور وفاء بتسلم على حضرتك، انا بحاول اعمل لها انميوت بس كل ما اعملها انميوت هي ميوت تاني.
خلاص يا فرق.
اتفضلي يا دكتوره وفاء، حضرتك ممكن
لا مساء
تعملي.
الخير سعاده البيه، بس اسمك انا قاعده دوشه مش عايزه اتعب حضرتك زياده يعني. ميرسي على المحاضره الجميله سعاده البيه، بس انا كان ليا سؤال how to suspect the malfunction of a pacemaker clinically. هل شكوى العيان ممكن تدايركت my attention ان البيس ميكر اللي اتركب ده فيه مشكله؟
احنا بنركب البيس ميكر رغم الانديكيشنز الكتيره دي كلها، لكن في الواقع ان هو بنركب البيس ميكر يا عيان عنده حاجه من اثنين، يا عنده سيمبتومز، ونقصد يمكن السيمبتومز هنا سينكوب، يا عنده كونديشن ممكن تبقى مور ريسكي. يعني هاي فاسيكولار بلوك ممكن تقلب كومبليت هارت بلوك، عشان كده بنتكلم على باي فاسيكولار. فكل الاساس هو السيمبتومز. السيمبتومز هو سينكوبي والجريد اللي اقل من سينكوبي، يعني ديزنس، نير سينكوبي، ده اللي احنا بندور. فالنمره واحد في الهيستوري هل العيان بيجي له سينكوبي ولا ما بيجيلوش سينكوبي؟ هل بيجي له ديزنس ولا ما بيجيلوش ديزنس؟ واخد بالك؟ نمره اثنين ان هو لو كانش العيان مركب له البيس ميكر عشان عنده سينكوبي، انما عنده موبيز تايب 2 بلوك وما هياش ماديه للسينكوبي، ليه بركب له انا ده؟ لان موبيز تايب 2 بلوك ممكن تؤدي الى ثيرد ديجري هارت بلوك، فوقعت في الجروب رقم 2. يا بركب بسينكوبي يا بركب لحاجه متوقع لو اتثابت
هتعمل هارت بلوك،
هتعمل سينكوبي. في الحاله دي هي ان انا اوردينري اي سي جي، اذا كان بقى الاوردينري اي سي جي موري انه نورمال كوندكشن والعيان عنده كومبلين بقى هولتر مونيتور. وي ار اندر يوتيلايزنج الهولتر مونيتور، وطبعا الهولتر مونيتور اذا كانت الموضوع انفريكونت بقى محتاج ايفنت ريكوردر وامبلانتابل لوب ريكوردر. من غير دول هم ما تقدريش تمارسي علم الاريثميا.
عيانين كتير من اللي بيتركب لهم بيس ميكر elderlies لهارت بلوك بيجوا يشتكوا من فاتيج، من shortness of breath، وبيبقى الاليمنت اوف diastolic dysfunction في الايكو very prominent.
العيان البيس ميكر اللي مركب بيس ميكر دي وبيشتكي من فاتيج، نمره واحد اشوف البروجرام بتاعه هو كله ايه. ممكن الار مش موجوده وبالتالي يكون عنده كرونيك تروبيك انكومبتنس.
اوكي.
ما عملتش الار اون، دي نمره واحد. نمره اثنين اللي هي مهمه جدا، بيس ميكر سندروم. بيس ميكر سندروم ده يؤدي الى فرايتي اوف كومبلينتس، من ابتدت ان هو فاتيج الى ديث، مرورا بكونجستيف هارت فيلير وهايبوتنشن وشوك. فالعيانين اللي هو مركب ديوال تشامبر بيس ميكر لازم ان انا افحصه. هل ديورنج الفحص ده عنده كانون اي ويفز؟ هل عنده
ده انا اللي كنت عايزه حضرتك تقوله. كلينيكالي عندي
هو
ساينز ممكن تخليني اشك ان
العيان اللي عنده مركب ديوال تشامبر بيس ميكر، لو هو هايبوتنسيف افكر في بيس ميكر سندروم. لو عنده كانون اي ويفز افكر في بيس ميكر سندروم. لو هو عنده كونجستيف هارت فيلير ما كانش موجود قبل ما اركب البيس ميكر، افكر في بيس ميكر سندروم. علاجها فيري سيمبل، you prolong the P valve. sometimes prolong the P valve مهما تبرولونج ايت ما توديهاش. ليه؟ لان الريتروجريد بي ويف واقعه متاخره بعد البي فالف. الحل بتاعها سهل جدا، انك انت تقللي البيسنج ريت عشان تخليه بالنيتف ريزم، وانك تقللي الاوتبوت بتاع الفنتريكولار الكترود، وبالتالي cannot be sensed by the atrial electrode. يعني تطوير البي فالف هو الحل، لكن في حل ثاني غير تطوير البي فالف. طبعا اذا كل الحاجات دي فشلت يبقى هتشيل الديوال تشامبر ميكر وتركبي البي ار يرير ريزولت تو ذات. So taking the history like in any branch of medicine is most important step. لكن ما هوش كل حاجه. Physical examination is very important. Measuring the blood pressure. Sometimes we البروجرامر نخلي العيان نحول من دي الى VVI and we compare two blood pressures. لما بنركب له دي نلاقي السيستوليك بلاد بريشر 80، لما نرجعه VVI نلاقي السيستوليك بتاعه 120. ايه الفرق؟ الفرق ان هو عنده بيس ميكر سندروم ما هوش فيري كلير، انما بيوطى البلاد بريشر. ايه اللي بيوطي البلاد بريشر؟ loss of atrial contribution and liberation of brain natriuretic peptide. هنا بدي هيبقى الاتريال natriuretic peptide reducing the vasodilation. treatment زي ما قلت elevation increase prolongation of the P valve or decreasing the ventricular rate and at the same time decreasing the ventricular output.
شكرا سعادة البيه.
سلام يا ست الناس. على فكره انا كنت بركب بيس ميكر لسنوات طويله جدا، لغايه ما لقيت العيانين بيجي لهم بيس ميكر انفكشن وبضطر اطلع البيس ميكر. في الوقت ده ربنا رزقني باحمد الضماطي. So all my patients are referred them لاحمد الضماطي.
هو الحقيقه كلنا مش حضرتك بس يا بيه. احنا دلوقتي كل
very capable. I think he's very capable. Unfortunately
الطقم بتاع الاي بي اس عندنا ما شاء الله is growing experience and number وبقوا بيشيلوا من علينا حمل كبير قوي. حضرتك هتدينا محاضره على الريسنكرونايزيشن ثيرابي ولا
المره الجايه يا ست الكل؟
ان شاء الله
المره الجايه اي سي دي وريسنكرونايزيشن ثيرابي.
اوكي شكرا.
دكتور محمد في سؤال هنا، إذا patient عنده ischemic heart disease وجاله وينك باخ، في انديكيشن معين للكورونر انجيوجرافي للبيشنتس دول ولا؟
الانديكيشن هي الانديكيشن بتاعت الاسكيميك هارت ديزيز
العاديه، يعني ما فيش سبيشال انديكيشن.
ما فيش سبيشال انديكيشن للوينك باخ. الوينك باخ دي يعني عباره عن very benign condition. It can be present because of hypervagotonia of any. واحد نام ممكن يجي له periods of وينك باخ، واحد اثليت ممكن يجي له وينك باخ، هو بيتآية او عنده جاجنج او عنده abdominal pain يجي له وينك باخ because of increased vagal activity. So there is no specific indication. The indication for a coronary angio is one of two things. أول حاجة ما فيش coronary angio إلا لو العيان accepting the principle of revascularization. If the patient says I will not do revascularization no matter what, أصبح contraindication لdiagnostic coronary angio. Clear. And the indication is one of two things: relieving the symptoms or prolonging survival. If you don't have one of these two things, then don't do coronary angio. Very simple. Very simple. زي ما سمع الانديكيشنز طبعا ممكن تبقى صفحتين فول سكان بس كلهم ريفولف. في الواقع الميديسن كله بيدور حوالين كده. الميديسن كله if you have gall bladder يا اما انك انت تشيل الجول بلادر because to relieve symptoms or انك انت prolong the survival. It's going to be gangrenous, going to rupture, produce peritonitis الى كده. لكن واحد ما عندوش symptoms لجول بلادر ستونز وما هواش في ريسك ان هو يرابشر هيز جول بلادر، بقى كونتروفيرشال انك تساله ولا لا. في ناس قالوا والله لو هو عنده كولانجيو كارسينوما سسبكتد او هو دايابيتك او هو الى اخره بقت كونتروفيرشال. لكن الميديسن كله هدفه انك انت either you relieve symptoms or you prolong survival. This is very clear to cardiology. So revascularization, if we do coronary angio, not because that's going to improve انتباه. We don't do this. The commoner question هو واحد عنده suspected ischemic heart disease or confirmed ischemic heart disease and atrial fibrillation. Atrial fibrillation has nothing to do with ischemia. The indications is the indication of ischemia. طبعا بقى ممكن تألف بقى تقول الرايت كورونري مقفول، الاستينود ارتري مقفول. There is no evidence ان دول كلهم من اللي بيعملوا atrial fibrillation، ولا لما تفتحهم الاتريال fibrillation تروح. مفيش حاجه اسمها كده، ولا كان في كده ولا هيبقى في كده.
هو كويس حضرتك قلت النقطه دي عشان حقيقي بشوفها كتير جدا حقيقي.
طبعا
كورونال انجيوجرافي في اتريال فايبريليشن.
atrial fibrillation
مفيش اسكيميا بيبقى كده بس انديكيشن في كورونال انجيوجرافي.
السلايد الاولاني اللي قلته النهارده سلايد مهم جدا. ليه بقى؟ لان احنا عندنا اتريال فايبريليشن بيخش الانتنسيف كير كتير لانه جاله سينكوب. السينكوب مش من الاتريال فايبريليشن، السينكوب من البوز اللي بعد الاتريال فايبريليشن. مهما كانت الاتريال فايبريليشن رابيد والventricular function is impaired, it's very rare to be responsible. So this patient you have to be cautious لانك انت if you defibrillate him سواء electrically or pharmacologically he might get into asystole for a long time. So you can do defibrillation. You can be prepared انك انت ممكن تلاقي pause يا اما انك انت transcutaneous spacing يا اما stand by transvenous spacing يا اما تركب له بقى transvenous spacing اذا كنت ما بتعرفش تركبهم بسرعه when demands when the condition demands that.
تمام يا دكتور محمد. هو مش شايف في اسئله ثانيه. لو حد عنده اي حاجه ثانيه حقيقي ممكن يكتبها لي دلوقتي.
أنا بس عايز أشكر الدكتور محمد ياسر وأقول له كل سنة وحضرتك طيب، وشكرا على المحاضرة والمجهودات العظيمة دي.
ربنا يخليك يا دكتور.
في انتظار حضرتك الجمعة الجاية إن شاء الله.
ان شاء الله. we hope ان الانترنت ما تخذلناش. اي اسئله عندك ثاني يا ياسر؟
لا خالص يا دكتور محمد، ما فيش حاجه ثانيه خلاص.
اوكي. I think ان الموضوع البيس ميكر ده موضوع مهم جدا، وسواء انك انت بتشتغل امبلانتر ديفايس امبلانتر او الكتروفيسيولوجيست او جنرال كارديولوجيست you should know fundamentals. You cannot say everything طبعا، ولا مفروض تعرف everything، ولا حد هيعرف everything. لكن الفاندامنتالز اللي احنا قلناها دي is sufficient to answer the examination and to practice reasonable medicine and to communicate with the electrophysiologist and the device implanter in a scientific way. شكرا جزيلا وتصبحوا على خير.
شاكرين جدا دكتور محمد، شاكرين جدا جدا.